Hello, my name is Matt Dito. This is my One Health presentation on malaria. This provides a quick overview of the topics that I'll be covering in my presentation: background, transmission and diagnosis, case management, treatment, prevention, novel techniques, and climate change effects on malaria. Malaria is an important disease that has a global distribution and significant health burden at the global and regional level. Malaria is a mosquito-borne infectious disease caused by protozoan parasites of the genus Plasmodium, and 4 species, Vivax, Malariae, Ovale, and Falciparum, in humans. Despite being a preventable and treatable disease, malaria accounts for about 212 million cases per year and 450,000 deaths globally in 2016. Sub-Saharan Africa continues to bear a disproportionate share of the global burden, with more than 90% of malarial cases and deaths, with Ethiopia as one of the hardest hit countries. According to the 2016 World Malaria Report, more than 1.8 million of microscopically confirmed cases were reported in the country. Malaria occurs in poor tropical and subtropical areas of the world. In many countries, it is the leading cause of illness and death. The most vulnerable groups are young children and pregnant women. Malaria is transmitted by female mosquito vectors of the Anopheles species. It can also be spread by blood transfusion, during birth, shared hypodermic needles, and organ transplantation. In the US, outbreaks of locally transmitted disease are small and relatively isolated, but there exists the potential risk for the disease to reemerge due to the presence of mosquitoes, especially in the southern states. Airport malaria refers to infections as a result of infected mosquitoes transferred from malaria endemic regions by aircraft. Clinical signs and symptoms of malaria are varied, ranging from absent or mild to severe and even fatal. This leads to the 2 categories: uncomplicated and severe. All clinical symptoms are caused by the asexual erythrocytic or blood stage parasites. Waste substances from the parasites, such as hemosone pigment and toxic factors, are released when lysed cells empty the invasive merozoites into the blood. Macrophage stimulation produces cytokines, which leads to fever and rigors. Symptoms are frequently described as fever and flu-like, and in an endemic area, this should immediately raise suspicion for malaria. Other symptoms are vague, like myalgias, headache, cyclical fever, sweating, and nausea and vomiting. Vivax and Ovale can have dormant liver stage parasites and can reactivate months after exposure. The incubation period ranges from 7 to 30 days, and shorter periods are associated with falciparum, and the longest is malaria. Long delays between exposure and symptoms can result in missed or delayed diagnosis. Severe malaria occurs with serious organ failure and metabolic abnormalities. Cerebral malaria is associated with impaired consciousness, seizure, and coma. Other symptoms are hemoglobinuria, acute respiratory distress, and metabolic acidosis. Severe malaria is a medical emergency and should be treated urgently and aggressively. Diagnosis is made by observation of intracellular parasites with the characteristic patterns of inclusions. Lab tests are nonspecific and may reveal anemia, leukopenia, and thrombocytopenia. The differential for malaria includes salmonella infection or typhoid, meningococcus, hepatitis, influenza, and leptospirosis. Rapid diagnostic tests using a dipstick provide results in about 20 minutes. These tests can detect 2 types of malaria, one specific to falciparum and another found in all 4 human species. Where malaria is not endemic anymore, such as in the US, healthcare providers may not be familiar with the disease. Clinicians seeing a malaria patient may forget to consider malaria among the potential diagnoses and not order the needed diagnostic tests. Laboratories may lack experience with malaria and fail to detect parasites when examining blood smears under the microscope. In some malaria endemic areas, malaria transmission is so intense that a large proportion of the population is infected but not made ill by the parasites. Such carriers have developed just enough immunity to protect them from malarial illness, but not from malarial infection. In that situation, finding malaria parasites in an ill person does not necessarily mean that the illness is caused by the parasites. Treatment of a patient with malaria depends on the country's national guidelines, which typically take the following into consideration: the type or species of the infecting parasite, the clinical status of the patient, such as HIV, pregnancy, drug allergies, and whether the infection was acquired, where the infection was acquired, and the presence of anti-malarial drug resistance. The choice of medication is based on the species it is identified based on microscopy. And some of the drugs recommended by the World Health Organization in the malaria endemic world are artemether lumefantrine, chloroquine, doxycycline, mefloquine, and quinine. In severe malaria, intravenous quinine is perfused. It should be noted that chloroquine and mefloquine are no longer effective in many parts of the world. High-risk groups are adults who have survived repeated malarial infections throughout their lifetimes. This partial immunity that they gain can protect them from severe or fatal malaria. However, because of changes in a woman's immune system during pregnancy and the presence of the placenta presenting a new place for parasites to bind, pregnant women can lose some of this immunity to malarial infection, putting them at risk. Malaria infection during pregnancy can have adverse effects on both mother and fetus, including maternal anemia, fetal loss, premature delivery, intrauterine growth retardation, and delivery of low birth weight infants. It's a particular problem for women in their first and second pregnancies and for women who are HIV positive. In endemic areas where transmission occurs in long seasons, fatalities are highest among children. In 2016, 86% of reported deaths in African regions occurred in children less than 5 years old. The main strategies for prevention are medicated nets, indoor residual spraying or paint that has medication embedded in the paint, vector control, and empiric treatment for pregnant women given the consequences. The World Health Organization has a 3-pillar approach to malaria as part of the Sustainable Development Goals. The main goal is to reduce the incidence and prevalence by 75% by 2025 and 90% by 2030. The development of a malaria vaccine, a main goal of prevention, has been difficult due to the lack of a traditional market and technical complexity of developing a vaccine against a parasite. Malaria parasites are also genetically complex, and exposure to malaria parasites doesn't confer lifelong protection as with some diseases. Acquired immunity only partially protects against future disease, and malaria infection can persist for months without symptoms. There are currently 2 vaccines with about 30% efficacy. The World Health Organization has set a threshold for recommendations of a vaccine being able to cover 75%. There are currently 12 vaccines in production with promising results. In this section, I'd like to briefly examine some of the more novel approaches to malaria and prevention and research. Control of the mosquito population is one of these goals. This is traditionally done with larval control by adding medication or oils to bodies of water where reproduction occurs. Another technique is habitat elimination. However, this is a challenge as shifting weather patterns and rapid changes in seasonal moisture are hard to predict, and therefore habitat destruction remains elusive. One of the more interesting techniques is to release sterilized male mosquitoes. This method is successful but requires high numbers of males, and this makes it unrealistic to deploy at large scales. New advances in genetic sequencing and application of CRISPR techniques also offer promises of genetic modification to prevent mosquitoes from picking up the parasite in the first place. Climate change. This was one of the areas that inspired me to study malaria in this section. I wondered how global variation in weather patterns would influence an infectious disease, and malaria was my chosen representative. Anthropogenic climate change is predicted to alter patterns of human health as the global temperature varies. As northern latitudes warm incrementally, new regions are open to increased breeding by mosquitoes. Predicting the effects of climate change is difficult, but there are several models that have been used to analyze, and they've come to common results. According to the best computer models, the most areas likely to experience significant effects are in African highlands, South America, and Southeast Asia. The impact of climate change on future malaria cases must be seen in the current context of a decline in global malaria, and projections often simplify the effects of land use change, population growth, migration changes, and economic development over the same period. Another study has predicted that climate change factors that support malarial spread may be offset by mosquitoes' own physiology. Mosquitoes are ectothermic, meaning that their body temperature is based on the environment, and warmer temperatures interfere with their body physiology and thus limits their spread. Therefore, while vectors may move into new highlands that are available due to warming temperature, They will also reach an upper limit of their temperature range in previously suitable environments. I hope I've shared some interesting facts about malaria and contributed a bit to our study of the global health impact. And have a good night, and thank you.